Okay, I think we'll start as people join. Thanks everyone very much for coming. My name is Emma Kalk. I'm an associate professor at SIDA, which is a research centre in the School of Public Health at the University of Cape Town in South Africa. And I'm also currently the director of SCAN, the Sub-Saharan African Congenital Anomalies Network. So thanks very much for joining us. And this is the last webinar that we have in the current series. So I'm joined this afternoon by an expert panel from across the globe, including Dr. Ayesha de Costa from the WHO in Geneva, Switzerland, Dr. Sreehari Nair from Kerala in India, Professor Michelle Abadingo from Manila in the Philippines, Mr. Emmanuel Kowero from Dar es Salaam in Tanzania, and hopefully, although he hasn't joined yet, Dr. Charles Kiaga from Kampala in Uganda. So in terms of housekeeping for the event, the webinar is going to be recorded, and for those speakers who've given their permission, the recording will be shared on the Sub-Saharan African Congenital Anomalies, or SCAN, a network website which is managed by the Global Health Network. To automatically translate the presentations into subtitles, you can navigate to the closed caption function and select the language at the bottom of the screen that's circled at the bottom. And owing to the number of participants, the camera and the microphone have been disabled, but please use the chat function to introduce yourself and to report technical issues. And if there are any questions, if you use the Q&A function, you can post questions and comments, and these will be answered during and after the presentations. We're going to take questions after all the presentations are complete, and at that point, either you can put your comments in the Q&A, or you can raise your hand and we can unmute you, so you can ask your question directly. Unfortunately, Dr. de Costa is going to leave before the end of the session, but hopefully she'll be able to answer questions in the chat. Okay, so our program is as follows. The topic today is universal newborn screening in low and middle income countries, and it's based on the premise that the WHO is busy conducting a consensus process looking at universal newborn screening programs across low and middle income countries, and screening for congenital disorders has been incorporated into this for the first time. So this is now then situating congenital disorders in the context of newborn screening and childcare. So we are privileged to have Dr. de Costa here to introduce the topic, and then we will consider the implementation of some of these screening projects in various low and middle income countries internationally. Next slide, please. So we have over 500 people registered today from across the world. You can see as demonstrated by this map, and so far over 140 people have joined, which is really great. Thank you. Okay, so our first speaker is Dr. Ayesha de Costa from the WHO, who will be speaking about the WHO framework on newborn screening, diagnosis and management of birth defects in low and middle income countries. Dr. de Costa is part of the Newborn Health Unit in the Maternal, Newborn, Child and Adolescent Health Department of the World Health Organization in Geneva, and works with research guidelines and programs in the area of newborn health. And she's currently leading the development of a WHO framework on newborn screening, diagnosis, and management. So thanks very much, Dr. de Costa. Thank you so much. That was an excellent presentation, and it provided us with very valuable context for the webinar. And also, I think it's quite important and pleasing that the WHO has taken this on and will be providing definitive guidance for people. And one of the things that we can provide at SCAN is a community of practice in terms of learning from the experiences of others. So thank you very much. If you have questions for Dr. de Costa, please will you put them in the Q&A function, and she will respond to them there. If we finish on time, she will be able to she'll be able to answer questions in person, but she does have to leave early. Our next speaker is Dr. Sreehari Nair, who is a physician with the Department of Health Services in Kerala in India. And he will be speaking on a population-based approach for screening, referral, management, and follow-up of children with congenital heart disease. Dr. Nair is a physician and public health expert and a healthcare strategist specializing in maternal and child health. And he conceptualized and implemented the Freedom for Little Hearts, which is a comprehensive congenital heart disease management program in India with real-time digital tracking for children with congenital heart disease. And he has spearheaded the country's first digital birth defects registry and newborn screening program. Yeah, Dr. Nair, thank you very much.
Thank you. Thank you, Iskan, for inviting me to present today. Good evening, all. And the forum is set by a wonderful presentation by Dr. Ayesha. And I would like to present a population-based approach that we initiated in the state of Kerala. We are a small state with 5 million births every year. And we are one of the states in the country, as Dr. Ayesha mentioned, among the LMICs, started an initiative to look at birth defects as one of the area that we need to start working around, being a state with lowest IMR in the country. So as you can see from the slide, India has a remarkable achievement in the last 2 decades in reducing the infant mortality rate. That is around 72 in 2000, and we are able to reduce it to around 28 as a country. And you can see at the bottom the blue line, that is Kerala, and in the next graph you can see we were stagnant at around 12 for almost 1.5 decades. That is the reason why we started thinking. And in 2016, when the country asked every state to have some targets for the SDG, and the state asked the Department of Health how we need to proceed. So a lot of focus interventions were done, and one among them was looking at congenital heart disease as a separate entity, and a special focus was given. And we were able to reduce our infant mortality rate to single digit 6 per thousand by 2020. So that story I'll be telling you now. So as I said, the government of Kerala asked the Department of Health how we need to proceed to put up a strategy for reducing infant mortality rate. The Department of Health convened various meetings with experts, the medical college professors, the professional bodies like Indian Academy of Pediatrics, Kerala chapter, administrators, program managers, and the whole data sets and available information were analyzed, and decided to go for special interventions like looking at infant death audit as a special program to understand the cause of death, what is contributing to the infant mortality, and a special program for congenital heart disease. Why congenital heart disease, I will be taking in the next slide. And looking at comprehensive newborn screening as a special program, because to improve the quality of life of children who are surviving. So this is why we looked at congenital heart disease as a specific entity or a special reason to address. Again, you can see almost 70% of the infant mortality in 2013 was contributed by the 3 causes, major causes: prematurity, birth asphyxia, and congenital anomalies. And out of the congenital anomalies, 50% of mortality were contributed by congenital heart diseases. So, being the highest prevalent congenital anomaly, that is possible, but we found that that is one of the areas that we can start working and address the issue so that the infant mortality can be addressed. So for that, the initial process was a situation analysis was done on human resources, infrastructure, current load of newborn cardiac surgery, the protocols available at that point, logistics, etc. And this is we were able to do with the support of one of the. It was a collaborative effort, that is with the support of an international NGO, based in US, Children's Heart Link. They helped us in developing that. And the findings were presented to the key decision makers at the state level. So this is the 2016 picture. We are a state, as I said, with almost 500,000 births every year. And the estimated congenital heart disease per year was around 4,000. We found that around 500 cases, infant cases, were operated during that period. And that resulted in around 650 to 750 infant deaths contributed by congenital heart diseases. So that is the reason why we decided to look at congenital heart disease as as an area where we can work around. And we were fortunate to have around 7 programs in the state, with 5 of them in private sector and 2 of them in public sector, 12 pediatric cardiologists and 10 pediatric cardiac surgeons in the state. So we identified our strengths and weaknesses. The important strength that we had was the political and administrative willingness to listen to the experts and look around and work at the important causes of infant mortality. And the desire to reduce IMR was another important aspect. And we had existing facilities, and even though they were majority of them were in private sector, they were ready to collaborate. That is another important aspect that we found, which was our strength. The weakness include late identification of the cases. The newborns with critical congenital heart disease were mostly diagnosed very late, and they were diagnosed most of the time when they were collapsed and admitted in the newborn ICUs. Deficiencies in the confirming the diagnosis. The echo, the experts to do the echo was not there in most of our districts. Financing issues. As I said, 5 of our institutions were in private, and mm, 2 of them were in corporate sector. And who will pay for the conditions? That was one of the challenge, and the payment systems and all were challenging. Poor awareness regarding stabilization and the timing of surgery among the healthcare professionals. That was one of the another issue, that some of the simple cases were sent early to the hospitals, or maybe those who are influential will reach the hospital first, and the marginalized people may not reach the hospital. That is one of the problem that we identified. And of course, the lack of transportation facility, especially for newborn, that was the problem. So, with all these opportunities and barriers, we defined a continuum of care. That is the first step that we did for the population-based approach. Uh, Being the first step as recognition of cases, then the diagnosis and prioritization. Because again, even though we had 7 centers and almost around 1,400 newborn cases every year based on the incidents, we may not be able to do all the cases at a stream. So we had to prioritize the critical cases first, and then we will be taking other cases in the list. So then, of course, the third step is referral, where to refer, when to refer, and who will be taking especially on the transportation part. The next block was stabilization and transport, keeping the child and making them stabilized, and then only we will transport. So, and the next step was treatment, of course, and with the last one being the follow-up in the community and the hospital-based follow-up programs. So, this is what we tried to do after the assessment. We looked at what were the things that we have and what not there, and what to be done, or how to take up this. So, giving an example, like we had some pediatric cardiologists and pediatric cardiac surgeons in 7 centers. 5 of them were in private, 2 of them were in public sector. We looked at that, and we found that some areas we don't have enough slots to operate. So the regional parity was not there. Dedicated pediatric labs and the cardiac pediatric ICUs were not there in public sector hospitals. The transportation was a challenge. There is no system for screening and referral. Uh, some areas we didn't have enough pediatric cardiac surgeons, and especially in public sector, we didn't have many surgeons to operate. So all these things we addressed in different with our different strategies, like to have a cooperation, like a public-private partnership was established, and some protocols were designed and defined to send cases to the hospitals, and making the entire pool of surgical slot in the state into a single pool where the state can send the cases according to the criticality and the need of the hour. And we decided to go for a screening program, and more diagnostic equipments were provided to the district level centers, and more people were trained to use this. So there was a financing strategy also was adopted. Prioritization was given to different things like short-term, long-term system building activities. And along with that, there will be the case management systems. The sources of funds were identified from the state funds. The federal government was giving some fund through the National Health Mission. Finance grants were available, and then all the development partners were asked to support the program. So the screening started. We decided to go for a screening program with pulse oximetry screening. A protocol was adopted for doing the pulse oximetry in 24 to 48 hours of birth, and the data was captured, and there is a facility to upload the data directly into the portal that we created for the program. Can see the name Hridyam, that is a program's name. So there is a portal developed, and the data from the pulse oximeters were directly flown to the portal. And along with that, we started doing physical examination, focused physical examination for cardiovascular system, looking for heart murmurs, low volume femoral pulse, the color of the baby, all those things. Also were looked and registered, documented in the portal by the nurses who are trained specifically to do this. All this data were coming to the district early intervention centers, where they will be registering the case after confirmation of all the screening positive cases. Like this is the flow diagram where it shows the pulse oximetry screening happens, and along with the CVS focus physical examination, all the screen positives will be sent to the pediatrician or the neonatologist available. From there to a referral for a referral for a confirmatory echo. The echo confirmed cases were registered to the Hridyam portal, and the cases will be classified in a non-critical congenital heart disease and critical congenital heart disease. There is a particular protocol designed with the support of the pediatric cardiologists and pediatric cardiac surgeons for categorizing the cases according to the criticality. Accordingly, the case will be referred to the centers for surgery or interventions. The non-critical cases will be kept under follow-up. There is a community-based follow-up system that we adopted, and based on the findings on a monthly basis, or maybe the data captured from the vaccination sites when the babies are referred come for the vaccination, they will be referred back to the pediatric cardiac centers. So all these things were published. We were able to publish it in I think in 2020 itself. We published the data, and this is the arbitrary categorization that we planned and developed. There are some categorization like category 1, 2, 3. The category 3 only needs medical follow-up. Category 1 is most critical cases, which needs to be operated within the first 6 months. The category 2 is again the primary surgeries and the stage procedures that are required for different congenital heart disease based on the criticality. So this is the flow diagram of entire program. The first line, the first verticals, the 6 pillars that you can see, the case registration. DAC is the District Early Intervention Centers, who is coordinating all the cases. Every district, we have 14 administrative units, districts. All 14 districts have a District Early Intervention Center. They will be sending the cases. All information will be provided to the experts, the panel of experts online, so that there is no need for referring the cases for taking a decision. The expert committee will sit, or maybe they will be seeing the cases online, and they will giving their opinion based on the categorization protocol that we have developed. Accordingly, the cases will be sent to the cardiac centers, uh, or maybe after they provide a date, and based on the choice and preference of the family, they can go to the hospital. The pediatric cardiac centers will operate or do the intervention accordingly, so that they can go home without any payment. The payment and other part will be taken care by government, based on the pre-approved rates and the agreement with the hospitals. That's what the public-private partnership worked. And after the treatment, once the case has gone, the child has gone to the community, to their family, the community level follow-up program will be initiated by the community nurses who are trained on specific modules on congenital heart disease management protocols. So this is what we have done from 2017. You can see every year more number of cases we were able to detect. That number you can see from 0 to 1 month that I have put in red. Every year, the numerator is the managed cases and the denominator is the registered identified cases. We are supposed to identify almost 4,000 congenital heart disease cases as per our birth numbers and the global prevalence of 8 per thousand. We were able to diagnose almost every cases, like 3,346 cases were diagnosed, and the numbers operated is based on, again, uh, for congenital heart disease, only 25 to 30% of the cases require a surgery in the first 1 year of life. So we were able to manage that many cases from 2019 onwards. So this is the follow-up program that we had. The pre-surgical case and post-surgical case had a separate follow-up program, and there is a neurodevelopmental outcome follow-up program was initiated for congenital heart disease as part of our rhythm program. The pre-surgical cases, as the non-critical cases, there is a particular protocol for different conditions. Like, see, the VSDs need to be followed up during the vaccination days and the initial months, and we try to operate all the cases of VSDs who need a surgery before 6 months, because we found that the VSDs were dying. Most of the VSDs deaths were happening around 6 months. So we modified the protocol at some point in 2020 and decided to operate all the VSDs before the age of 6 months if they need a surgery. And for the tetralogy of Fallot cases, usually get operated around 1 year as per the global consensus. So we try to do all these things as per the evidences available globally, and change our protocols according to the evidences that we had. So this is the neurodevelopment follow-up program that we had. A specific neurodevelopment outcome follow-up program was defined and designed for the state based on the requirement and the challenges we had, and including the facilities that we had. So again, district early interventions, the pivotal, the tool from India, DASI, was used for the assessment of these children. So talking about the success, maybe three things I need to tell you. The focus was maybe I will say the uniqueness of the program first. That there is a first of its kind in the country. Nobody has thought about such a program. That is, second is cashless treatment. The family need not worry about any money. Once it is diagnosed and if they got registered in the portal, then it is the responsibility of the state to take care of the whole case management. And it was a web-based single registry which helped us to have the numbers and, of course, the follow-up of individual cases, and that helped the state to plan the program as well. There was Before that, there was no definite period. The families didn't know that when the child will get operated. Now the waiting period becomes finite. They know once they're registered when it is going to be operated, or when they need to be get operated, when they need to go, where they need to go. All those things they know also. So there is a transparency. There is a centralized surgical referral pattern was developed. All the surgical slots, as I said, in Kerala are made part of a single pool, so that any critical child can be referred at any point to these centers. So capacity building and technical sort of development of the health system was part of this initiative. We focused on that. Early identification of cases, including fetal heart screening, was one of the objective of developing health system in this program. So we were able to publish the data for the program as a population health approach to address the burden of congenital heart disease in Kerala, and that came in the Global Heart. And as I said, we were able to reduce our infant mortality rate. That is significant. That is not only because of the congenital heart disease program, but of course, with the developing congenital heart disease program, we were able to bring in a lot of other changes. We found that we had some flaws in managing the newborn units, or maybe the developing capacities and improving the technical skills of the nurses and doctors in these units. All these things contributed to that. We have a screening program. So the screening for identifying and surveillance registry created for the state. This helped us in developing new policies, or maybe shaping our policies for newborn care as a whole, and not only for congenital heart disease. Now the systems are in place based on this care pathway defined, including the community level follow-up program and neurodevelopment outcome follow-up is happening. The strategy was to prioritize cases based on criticality and availability of surgical slot. That is one of the major challenges any low and middle income country is going to face when you're going to start such a program, and that is very important. Thank you.
Thank you so much. Thank you for your presentation. It sounds, it seems to have been a kind of complete success. And what's important, I think, is that it's a comprehensive program and it's longitudinal. So it goes beyond the newborn period, which is ideal. I also think that it emphasizes the importance of web-based systems and linkage across different centers. And I'm becoming a more and more firm believer in data linkage for patient management and for surveillance. So thank you very much. There are already some questions for you in the Q&A section, and other questions we can speak to after after all the presenters are complete. Our next presenter is Assistant Professor Michelle Abadingo, who is a pediatrician and with specialist training in clinical genetics. And she is currently the director of Newborn Screening Reference Center at the University of the Philippines National Institutes for Health, which serves as on the technical arm of the Department of Health, implementing the newborn screening programs. So Professor Abadingo is going to speak to us on the Philippine experience using newborn dried blood spot screening. Thank you very much.
Good morning, good afternoon, and good evening to everyone. I'm Michelle Abadingo, and I will discuss the Philippine experience on the national implementation of newborn dried blood spot screening in the Philippines. The following are the objectives of my talk. First is to give an overview of the newborn dried blood spot screening program in the Philippines, and to provide updates on the Philippine newborn screening program. Before I start with my formal discussion, I would like first to give an introduction on the Philippines. It consists of more than 7,600 islands with 3 main island groups, which are Luzon, Visayas, and Mindanao. The Philippines has 18 administrative regions with a land area of 300 square kilometers. As of 2023, our population is around 115 million, and for the same year, the registered live births in the Philippines is 1.4 million. So newborn screening actually started as a research project in the Philippines way back in 1996 to establish the prevalence of 5 congenital disorders. Newborn screening was piloted in 24 hospitals in Metro Manila, And during that time, 100 samples were sent to a laboratory in Australia to run the dried blood spots. Currently, we have around 7,000 birthing facilities. So when we say birthing facilities, this includes the hospitals, the lying-in clinics, all across the Philippines. And the seven newborn screening laboratories in the Philippines receives around 4,600 samples a day. Some of you might be already familiar with the system flow. The slide shows us the newborn screening system flow in the Philippines. Um, anyways, so healthcare providers, so this includes the physicians, nurses, and the midwives, are trained regarding the importance of newborn screening, so that the healthcare providers in return would be able to discuss to the parents or caregivers the benefits of newborn screening. Now, the child is born in a newborn screening facility. So these are hospitals and birthing centers. And here in the Philippines, the dried blood spot screening is done a little after the 24th hour of life. Daily, the samples are sent to the newborn screening centers via courier service. And they have a laboratory section in the newborn screening center that runs the samples. All results of the newborn screening goes back to the newborn screening facility, and each newborn screening facility has what we call the newborn screening coordinator. Now, what happens if there is a positive screen? Now, they have the newborn screening center has a follow-up team, short-term follow-up team, and they also contact the newborn screening coordinator of the facility where the patient was born, so that the patient can be recalled for confirmatory testing. Now, once a diagnosis has been made, or we already confirmed the diagnosis, the patient is then endorsed to the long-term follow-up or the newborn screening continuity clinic for long-term care. Now, this slide shows us the timeline of implementation expansion of the newborn screening program here in the Philippines. So we've mentioned earlier that it started as a pilot project to establish the prevalence of 5 congenital conditions. So this included congenital hypothyroidism, congenital adrenal hyperplasia, phenylketonuria, homocystinuria, and galactosemia. Now, what I would like to point out in the journey of the it is for the Newborn Screening Act or Republic Act 9288 was enacted. So this law gives the opportunity newborn screening. What I would also like to highlight in the timeline of the Philippine newborn screening program is that quality assurance was started in 2006. So we implemented the guidelines or the checklist from the US program. And we use this to evaluate the laboratories. Now, we have two international accreditors in that helps the program review the processes in the newborn screening laboratories. In 2014, we could see that we started the optional expanded newborn screening program. So we started screening for initially 5 and then 6. And then in 2014, 21 additional conditions were added to the panel as an option. It was also during this year where the newborn screening program was able to establish what we call the newborn screening continuity clinics. So the newborn screening continuity clinics serve as the medical home of our confirmed positive patients, and they take care of the long-term follow-up of our patients, because we believe that it is not enough that we screen the patients for the disorders. What is more important is that we would be able to follow them up and make sure that they're able to grow at par with age. Now, at 2019, we can see here that the expanded newborn screening was no longer optional, because it was already covered by the Philippine Health Insurance, that is the national insurance of the Philippines. And in 2020, we see here the establishment of what we call the Center for Human Genetic Services. So the Center for Human Genetic Services provide technical expertise to the newborn screening continuity clinics in the management of patients with inborn errors of metabolism. I've mentioned in the earlier slide regarding the legislation which supported the implementation of newborn screening in the Philippines. So again, to reiterate, it highlights that the newborn screening system shall ensure that every baby born here in the Philippines is offered the opportunity to undergo newborn screening and thus be spared from heritable conditions that can lead to mental retardation and death if left untreated and undetected. Now, there are four important components in the newborn screening law. First is that the law defined the Department of Health as the lead agency in the implementation of the program. Second is that the law established our office, the Newborn Screening Reference Center, as a technical arm in the implementation of the program. It is also under this law that obligated healthcare workers to inform the parents or legal guardians of the newborn regarding the availability, nature, and benefits of newborn screening. And lastly, the Department of Health and the PhilHealth or the National Insurance here in the Philippines shall require health institutions to provide newborn screening services for licensure and accreditation. Now, I've mentioned that we are using the Philippine Performance Evaluation and Assessment Scheme or the Philippine Peace Tool in evaluating the quality of the different aspects of the newborn screening program. So this was modified from the newborn screening system performance evaluation assessment scheme from the United States. So currently, we have a PEACE tool for the evaluation of the 17 Department of Health Centers for Health Development. So when we say Center for Health Development, these are the regional offices of the Department of Health. And they have what they call the newborn screening coordinators. So we assess if the newborn screening coordinators of the different CHDs were able to implement newborn screening well in their respective regions. We also have around 7,000 newborn screening facilities, 7 newborn screening centers, and 33 newborn screening continuity clinics. This slide shows us the newborn screening centers currently here in the Philippines. So we have 7 newborn screening centers. 4 are in the main island of Luzon. 2 are in the main island of Visayas. And there is 1 newborn screening center in Mindanao. Hopefully, by the end of the year, we would be able to start the operations of the newborn screening center in Legazpi City. So this is in the Bicol region, a province in Luzon, and in Cagayan de Oro City. So this is located in Mindanao. Now, aside from the newborn screening centers, we also have the referral network. So we've seen in the earlier slide the 7 newborn screening centers. So in this slide, we will see the 3 centers for human genetic services. So as mentioned, it provides technical expertise to the newborn screening continuity clinics. Currently, we have 33 newborn screening continuity clinics across the archipelago. They are hosted in government tertiary facilities. And as mentioned, they provide long-term care to our confirmed positive patients. And we also have what we call the satellite clinics. The satellite clinics are based in primary facilities, which may be present in far-flung areas. So as you can see, we are an archipelagic country, and some provinces may be far from the continuity clinics. So the satellite clinics would help in seeing the patients, and then they would refer these patients to the continuity clinics. Now, this slide shows us the journey of the Philippine Newborn Screening Program. So as you can see, this is the national coverage of the Philippine Newborn Screening Program when it started in 1996. We are a work in progress As of 2024, our national coverage is at 91.8%. What I would also like to highlight from this slide is that at the peak of the COVID-19 pandemic, our national coverage did not go below 80%. So when the pandemic started in 2020, our coverage was at 89.5%. And at 2021, our coverage was at 88%. And at 2022, it was at 90%. This slide, on the other hand, shows us the current disorders included in the expanded newborn screening panel. So for the endocrine disorders, we're currently screening for congenital adrenal hyperplasia and congenital hypothyroidism. For the inborn errors of metabolism, here are the amino acid disorders that we screen. In this, we would see the fatty acid oxidation disorders, the organic acidurias, and the urea cycle defects. The program detects detectable hemoglobinopathies and thalassemias, and the other disorders that we screen include biotinidase deficiency, cystic fibrosis, galactosemia, and glucose 6-phosphate dehydrogenase deficiency. This slide, on the other hand, shows us the selected newborn screening statistics in the Philippines. So, to your left, what I would like to highlight is that the most commonly screened disorder in the Philippines is G6PD deficiency, which has a prevalence of 1 into 62. As for the metabolic disorders, the most common would be maple syrup urine disease, and it has a prevalence of 1 in around 63,000. Now, on your right, you would see the statistics for the hemoglobinopathies and thalassemias. So you would see that the highest prevalence would be the hemoglobin H disease. What I would also like to highlight regarding the Philippine newborn screening program is the presence of collaborations. In this slide, this highlights the experts panel. So there are experts panel per disorder groups included in the newborn screening program. So the panel consists of subspecialists and experts on the particular disease disorder that they belong to. Now, this group helps in the review of the data sets and algorithms. So this helps us make sure that our algorithms are up to date and that our program is sustainable. They also review the protocols for confirmation of disorders and treatment. And they also help in addressing frequently asked questions from doctors and patients. Um, I highlighted in an earlier slide that one of the main thrusts of the Philippine newborn screening program is education. And we have our website at newbornscreening.ph where we could see different resources on newborn screening. So we would see here some fact sheets and brochures on the disorders included in the newborn screening panel. We have a partnership with the University of the Philippines Open University, and we have a show called a Newborn Screening in Focus. And this is seen in the internet channel of the University of the Philippines. The show basically discusses the administrative and medical side of the newborn screening program, and it also highlights the disorders included in the newborn screening program. So this helps the general public to be more aware regarding the availability and the benefits of doing newborn screening. Despite the 28 years of the Philippine newborn screening program, we still do have our share of challenges. So, first is the timeliness of the receipt of newborn screening samples in the newborn screening centers. The early receipt of samples would help in the prompt recall, especially of positive patients, and it would also help in the closing of cases. I've mentioned that the Philippines is an archipelagic country, and we have our depressed areas. So accessibility may also be a concern here in the Philippines. So there may be not all areas may have equal access to information, confirmatory centers, and specialists needed. For our confirmed positive patients, we still need to make sure that they are adherent to treatment and management. And being in the Pacific Ring of Fire, the Philippines is also prone to natural disasters, and we have experienced during the pandemic the challenges. Underwent challenges during the COVID-19 pandemic. So again, as a summary, I gave an overview of the Philippine dried blood spot screening program, and I also highlighted some of the updates on the status of the Philippine newborn screening program. And with that, I end my presentation. Thank you very much, and I will be happy to answer your questions later on.
Thank you so much. It's another excellent and resilient resilient program, and one wonders if one couldn't piggyback this sort of thing. I mean, for example, in South Africa, we collect dry blood spots at birth for HIV diagnosis in babies that are exposed to HIV. So I think one of the things that the last two presentations have emphasized is the necessity for political will at quite a high level and allocation of budget centrally. Thanks very much. Our next speaker is Mr. Emmanuel Kowero from Tanzania. He is a project officer for the Clubfoot project at the Management and Development for Health, and has 10 years of experience in Clubfoot treatment, and is a certified Ponseti practitioner and trainer. And he has trained over 400 healthcare professionals in Tanzania and beyond, and also provides supportive supervision for 70 Clubfoot clinics across the country. And Mr. Kowero is going to speak to us on the experience of clubfoot treatment in Tanzania. Thank you very much.
Thank you very much. Good afternoon, good morning, good evening to everyone. I know we are talking to everyone across the globe. I am glad that we are here today. I'm going to take you through the Tanzania Clubfoot program experience, and mostly on the early detection and referral. As we all know, that clubfoot is the condition that is present at birth, where a child is born with either one or both feet turned inward and pointing downwards, kind of rotating, and the sole of the foot pointing upwards. And around the globe, it is estimated that 1 out of 1,000 live births occur worldwide each year, and most of these, about 80% in the low and middle income countries. And the causes of clubfoot, over 70% of the causes is not known. It's in idiopathic, but there are theories that are suggestive of genetic component being involved and environmental factors due to the positioning of the child in the womb or other environmental factors. And if this condition is left untreated, normally it ends up in a permanent disability, difficult walking, and as we know in the context, we also have social stigma around these people with an untreated clubfoot. And if it's treated early using Ponseti method, the experience shows that above 95% of these cases end up with successfully corrected and normal feet. Why are we talking about early screening for clubfoot? It's because early detection will always allow timely correction. So once we detect early, we are able to correct early and prevent the lifelong disability. And also, this is going to help us reduce the stigma within the society, because most of the children will get to know they had clubfoot when they are grown up, if it happens that the family kept their photos. But otherwise, they will be corrected before the age of 1 month, and they will never know that they had clubfoot, so stigma is not part of their lives. But also, this reduces the economic burden on the families if we correct early, because there are other cost-related factors when it comes to surgery. But this one is also supporting the universal health coverage. In Tanzania, it is estimated that approximately 3,000 new cases are born each year with clubfoot, and the current program is able to see about 2,000 new patients annually. So we still have a burden of 1,000 cases that are either treated elsewhere where we are not in connection with, or else they are not treated in the routine healthcare. And most rural areas are lacking clubfoot clinics, from the district down to the because of that are missed during postnatal checkups, leading to delayed in detection for these kids. And a community-based decentralized approach was really needed to make sure that we are able to reach out to most of these children. And it was led by the local partners under the Ministry of Health, and most of the funding coming from Miracle Fit, a USA-based organization. So integrating screening into the routine care through the maternity wards and primary health care centers has been one of the key areas that lead to achievements in our program, because of the ongoing trainings that we provide to the nurses, doctors, to ensure that they are able to detect early. And over 600 healthcare workers have been trained in country, including those we support and those we don't support, but mainly focusing on the early identification. And about 75 clubfoot clinics are supported in the whole country. As you can see the map, we have the clinics supported by the program across the country, from the primary, secondary, and tertiary level, but most of them are the tertiary and secondary level, with quite a large number of unsupported structures within the primary level. Therefore, we were able to develop strong referral and follow-up system through the software called CAST application using ComCare, where we give mobile phones to the providers who are able to communicate within themselves by referring patients, by also using that system for decision-making. But we have coordinated early detection and referral training and campaigns that are ongoing in each of the facilities, using the healthcare providers who have been trained already to be able to train others on early identification and referral, and at least to be able to have each region with key trainers to be able to train others. But we have a large campaign on community awareness and raising. If a child is missed at the hospital, then the community should be in a position to identify these cases and refer. And mostly using community healthcare workers network that is available at least in all villages, making sure that they can be able to see clubfoot and refer immediately. So since 2015, these campaigns have been tried at different places, scaled up from the few clinics that we had by then, and almost 13,000 children have been treated through this program, and over 90% success rate in treatment completion during the Ponset method. And we have most of the children working independently in this program. So if you look at the statistics, we started back in 2015 with the list number that was around 519. And the year 2024, we were talking of close to 2,000 patients. We are remaining with some few months before we come to the end of this year. And therefore, we are almost there, hoping that we'll be able to see 2,000 new patients across. So the increase in number of patients is because of the trainings that have been ongoing in the supported and non-supported hospitals, ensuring that when the child is born, they do a physical check immediately and they're able to pick the clubfoot features, and they know where to refer with the phone numbers and posters available in most of the clinics within the country. So as other programs, we have noticed some of the few challenges that someone may learn from us and improve their own programs elsewhere, but mostly is an inconsistent early identification and referral campaigns in some of the remote and hard to reach areas. So this has been always a challenge, and we have been trying to work closely with the Ministry of Health and the President's Office, making sure that we are able to use the available existing structures within the government to reach to those places. But mostly training and remote supportive supervision has been the key. High staff turnover and limited access to trainings in most of the places has been one of the challenges for the program. You train 10 providers today, and tomorrow they all leave the places, they go to school, and then you have to retrain. So that has been a way we replace this staff. There has been transport challenges, especially to those rural families, and this has been one of the key emphasis for us to be able to support most of those families with at least transport subsidies, or use the available local means of transport to bring them back to the clinics. And this somehow results into high dropout rate, and especially during the bracing phase. And another thing is cultural beliefs, stigma, that leads people to delay seeking for the healthcare services. Apart from that, we have learned quite a lot through this program, and several issues that we have learned is that if you conduct early identification and referral campaign through training of the healthcare workers, through training the community members, through using the community healthcare workers, you are in a position to at least have your targets and the goals achieved early, because the goal here is to make sure that we have more children coming in below the age of 12 months. And that has been one of the KPI that we have performed above 80% because of the trainings that have been going on. So if you invest more on training healthcare workers, educating the community members, having the key champions from the community, that one is going to be a very successful program. We have continuous trainings at facility levels that has given us a very good result, because from the pre-training, now you see people going out there and do some practical works, and that one has been very effective in ensuring that we will maintain the quality of treatment, but also we are able to reach out to the communities across the country. And also we have been working with the Ministry of Health and the government to embed the screening routine newborn care. And that one has been very crucial, because after this one, we move into the curriculum development to ensure that we have key components to identify clubfoot and other birth defects in country. And that has been an ongoing job, although some trainings have been performed in some places to ensure that at least we have people who are keen to be able to identify. Real-time data also is very helpful, because if you don't have a data system that is going to be able to capture some information, you are not in a good position to make decisions. So using the CAST application, we have been able to make decisions based on the data that we collect from different parts of the country, decisions on what type of training is needed, growth and expansion of the program, what else do you need to do in terms of piloting different techniques on early identification and referral and awareness. So the data has been informing the program so much. And the clubfoot model, we believe that it can be scaled to other congenital anomalies screening, like spinal bifida, cleft lip and palate, and being examples. And this one has been tried in our program, and we realized that it's working. In conclusion, our experience demonstrates that universal newborn screening for clubfoot is feasible, effective, and impactful, especially in the low middle income countries. And this one is one of the cases that we can be able to recommend for the rest of the programs. And we want to acknowledge the support we get from the government of Tanzania, Miracle Fit, and all implementing partners across the globe that has been supporting this program to make sure that we have a school that people can learn and be able to implement this. So here we say, until everyone is healthy. Thank you.
Thank you very much. That's another excellent and effective program. And I think you highlight an important point, which is part of all the presentations we've seen today, is that embedding screening in routine newborn care is fundamental. So thank you very much. Unfortunately, Dr. Kiaga hasn't joined us this afternoon, so we have time now for questions. I think some have been answered in the Q&A. If your question has not been answered and you would like to raise your hand and ask a question directly, now is your opportunity to do so. Otherwise, I'll go through some of the unanswered questions. and we can respond to those. Unfortunately, Dr. De Costa has also had to leave us to attend another meeting. Louis, will you look at the hands?
Yes, I'm on that.
There's
So I
one.
can see that,
Yeah.
yes, Sarah's got her hand raised, and I'll allow you to talk, right? Sarah, so the procedure is raise your hands and I'll unmute you. Just make sure you've prepared the question, make sure it's a question that's not too specific and that that can actually be addressed as a general question. Thank you.
Okay, thanks very much. I think that's Sarah.
So you should be able to talk now, Sarah.
Yes, good afternoon, good evening, morning from everyone where is watching me from. I'm called Inembabazi Sarah from Kampala, Uganda. I'm a midwife by profession, working with the biggest hospital in Uganda, that is Mulago National Referral Hospital. We did a research about heat stable carbetocin. It's a drug that controls uterus atony. But we haven't implemented it. I don't know what you can say about it, because what we use is oxytocin, misoprostol, and actually manual procedures. So my question is, when is this drug going to be implemented? Because when you look at its storage, how the contraindication, the indication, it's suitable for use both in rural, urban, and urban areas. Thank you very much.
Thank you. I'm not sure if anyone on the panel has experience with this drug. I think they generally with medications, takes a number of years for a drug to get approval and registration after many years of research and applications. Is there anyone on the panel who has experience with this medication? Okay. All right. Unfortunately, then we'll move on. Are there any other questions that would like to be asked directly? I don't know. Oh, okay. I was also going to say, Erica, you had a question about transport in India and South Africa. If you're still on the call, you can ask that directly. Abebe, sorry.
Hello, can you hear me? Can you hear me, please?
Yes, we can hear you.
Hear you.
Thank you very much for the nice, wonderful, and timely presentation. I am Gibramlak from Ethiopia, Tigray, low and middle income country. So my question is regarding the universal coverage of newborn screening. So how do you see in case of feasibility? Because there are many economical constraints in developing country. In my region, Tigray, because of the war, a lot of congenital anomalies are happen. But because of the culture that we have, we didn't reach them. Even they didn't get medicine. So regarding the economy in developing country, how can we proceed with the universal newborn care, newborn screening for birth defects? I thank you.
Thanks very much. That's the key question. I mean, maybe each person can briefly say how they in their specific country have addressed this. Michelle, do you want to begin?
Okay, I can start. Actually, we're doing a pilot of the screening of visible birth defects in the Philippines, because we also plan to implement this nationwide. So what we're currently doing right now is that we have 104 newborn screening facilities that volunteered to join the pilot the pilot visible birth defect screening. And what we're currently doing is that we are implementing the project in phases. So we're currently in the first phase of the project. So for the first phase, we focus on four birth defects. So that would be your cleft lip and palate, your abdominal wall defects, your club feet, and your neural tube defects. The second phase of our project would be the birth defects where you need devices. So this includes the critical congenital heart disease and the hearing screen. And the last phase of our project is the multiple congenital anomalies. So hopefully we would be able to see the concerns while we're doing the first phase, so that we would be able to improve the implementation on a nationwide scale. But for the data regarding visible birth defects, the implementation of visible birth defects in the newborn screening program, the Philippines is also just starting.
Thanks very much, Dr. Sreehari.
Actually, that's a very good question. This is where almost all the program managers and the government stuck. When to start the screening, or where to start, or which condition they need to identify for screening. Whether you have systems incorporated to the health system to manage the cases. So my point, when I was a program manager, when we started the comprehensive newborn screening and the congenital heart disease screening program in the state of Kerala. So the same question was asked by experts to me also. So my point was, we need to start somewhere. And now the experts have almost agreed that the number IMR has nothing to do with the timing of starting any screening for congenital heart disease. That's mostly because it's maybe significant statistically, only because we don't have the exact prevalence numbers. We don't have it. We have only estimates and projections for most of the countries. With available information in hand and looking at the projections and the cost involved in managing the conditions in the later life or the management of disabilities affected, it is high time to start screening for at least some of the conditions which are already proven. There is no need for any local evidence. That is what people every time do. Try to do some pilots, creating evidences. That's actually, there is no need. Most of these things are already, we have proven, especially hypothyroidism. It's very significant. Sickle cell in most of the African countries and in India. We have already proven it. This is significant. And the burden on the health system and the cost on rehabilitation and other things, the life saved, these are all proven if you start doing screening. So that was the point that we argued as people for starting screening. And fortunately, there was a high level of political will, and we were able to negate for it, and it happened. So any country can plan screening at this point. There are challenges, of course, there are challenges, specifically going for congenital heart disease screening using pulse oximetry. The equipment is a challenge. What type of equipment that you're using? The people needs to be trained properly. These are all some of the findings that we told in the paper that I shown. So that is my point. It is not only the blood spot screening or the visible birth defect screening. In India, we have a very beautiful program, Rashtriya Bal Swasthya Karyagram, RBSK. That is a federal government implemented program. All the states are implementing that program now. That starts with the visible birth defect screening in the first 24 hours, identifying clubfoot, club clip, all those the visible conditions in the first. Then in the next 24 hours, we'll be looking for heart diseases, the hearing screening, all those things. And before leaving, the blood spots, at least for the first 4 parameters that we are doing. So So my point is that all the countries should at least start doing it. They need to start somewhere. Then only we will be able to. All the countries who have done it, that did like that only.
Thanks very much. And I mean, I know in parts of Cape Town here we also have pulse oximetry screening at the peripheral sites, the primary healthcare sites. Emmanuel, your response to the question about funding?
Yes, there is always somewhere to start, even if you are in such difficult situations, being in a war zone, being in a place where you don't afford funding to be able to run a national program, but there's always somewhere to start. I was thinking of prioritizing what are you going to start with? In my side, I would think of physical treatable birth defects, talk of clubfoot, talk of something that you can easily see and diagnose right away. That could be the low-hanging fruits. That's where you can start. So at least start with with what we can be able to see and say exactly that is clubfoot, and that is the starting point. And secondly, there has to be a way that people are getting treatment in these areas. Despite the war situation that is there, people are at least accessing treatment services at the primary healthcare services. If we start with the primary healthcare services, at least organize an online training to the healthcare workers there. If you are in a place where at least you can access internet, create a way that you can be able, either through phone calls, through Zoom calls, through WhatsApp calls, at least be able to talk to a healthcare worker at the primary healthcare level and give these skills on how to identify the physical treatable conditions and what can be done at least. So through that priority and through that line, using technology, you're in a position at least to send a message. If you cannot call a training and say people should travel, then let them sit in a room, offer the training. That is another option. And the third one, we don't have to reinvent the wheel and come up with completely a new thing. We have to think on how are we going to integrate the newborn screening services within the existing structures within the government. There has to be something that is connected with the government that is doing. For instance, we have the government implementing immunization campaigns. If somebody is going to a clinic to offer immunization, that person should at least be able to stay there for a week and see a child who is walking and say, this child has 1, 2, 3 physical and detectable conditions. So if we embed the screening into other programs like immunization, like we have eye programs that are ongoing in our countries. We have I know of some countries where they have massive male circumcision campaigns. The same healthcare provider who is a medical doctor, a therapist, can be trained to be able to see other things beyond what he or she is going to do there. So we don't have to think of a newborn screening as the new thing that is emerging, but how can we use the existing structures to be able to reach out and touch something else apart from only focusing on one thing? That's what I would recommend.
Okay, that's excellent advice. Thank you very much. Erica has a question, and then after her, Dr. Anne.
Sorry, shall I add one question? Excuse me.
Oh, okay. Do you have a follow-on question?
Yeah.
Okay.
Thank you very much. I'm very happy by the responses of our presenters. Thank you very much. So I have one question also, two oral question. How do you see community engagement with the comprehensive newborn record screening? What is your experiences? I think in this case, sustainability issue comes. So I love the word integration, which is good with the existing system. But what about the community engagement regarding this one? The other one is the institutions, especially preschool students should learn on the universal screening of or comprehensive newborn screening. So do you have an experience with the institutions like higher institutions, health science colleges to integrate this issue in their curriculum? Thank you.
I think your question is about community engagement and perhaps about teaching. I mean, if the panelists could briefly respond to that, because we need to save time for other questions. Dr. Sreehari?
That's a very valid question. The community engagement is maybe, I must say that that's the most important thing. If you have strong community engagement, two things will be solved. One, getting all the children screened can be easily done. There will be mouth-to-mouth publicity. That's what I heard from many of the champions who have done it across the world. Second aspect is, if in case there are some challenges, the government changing, or in that aspect, if somebody is even thinking about stopping the program, there will be a cry from the community. So that two aspect, community engagement, if we have strong community engagement, that will definitely help in sustaining the program. Training, yeah, definitely. It should be all the training institutions should be part of these programs. They need to be updated. The curriculum should be modified accordingly. Many countries, even including my country, many of these programs even are not part of the medical education or the nursing education curriculum. The problem will be like, we will have to retrain them when they come to the services, when they become the staff. So that can be avoided if we have these are part of the curriculum.
Thanks very much, Emmanuel. Do you have experience of this?
Yes, I wish to say something on community engagement. It is again what is working within your context. For instance, in my country, we have tried in the program to segment the community. So we have we look at those people or leaders within the community who people do believe, like religious leaders. So we tend to visit them during their congregations, sit with them and talk about a certain condition, show them pictures, prepare some materials that are simple and can be understandable. So they read and they preach it in their sessions, and they refer people to us. So it depends on what works best in your country. For instance, my structure in the country has got village leaders and village meetings. So engaging the community doesn't really need a lot of funding. Sometimes you need to seek for an opportunity to present in the village meeting, and that works very well because that is the place where people are living, not within the urban areas. For those in the urban areas have full access to screening and everything. But if you embed this program down to the community through the structures in the religion, local government authorities, other gatherings that can bring people together, have your time, give speech there. That's another way of reaching out to the community. In terms of institutions, it depends on the structure of education within your country. In the healthcare structures, it may be easy for you to recommend to the ministries and input something within the system through your curriculum. Now you should be able to come up with at least a guide on what you want to teach these people. And then there has to be a process that has to be followed. For instance, in Tanzania, you can't just come up with the module without its approval. So there are medical council bodies that has to review the content, approve the content, and then allow it to be part of the training curriculum. We have tried that here and it works very well, but you need to have at least a content of the training course, get it through the agreeable system and the structures, and then it gets approved. For instance, we have our clubfoot course, the basic postage course, approved with the Medical Council of Tanganyika, and it gives out 10 CPD points. So the same thing can be rolled out elsewhere, but it all depends on the structure and the regulations that are governing this area. But it's very crucial and very important.
Thanks very much. And Dr. Michelle, any experiences from your side?
Yes. Regarding the community engagement, what I've learned from the newborn screening program is that you need to work with the healthcare workers in the grassroots, especially in our geographically isolated and depressed areas. So these are the healthcare workers that goes house to house to check on the patients, and these are also the healthcare workers that help the program in recalling the screen positive patients. Now, regarding the geographically isolated and depressed areas, we also look into areas where we have a low coverage for newborn screening. We try to understand what is happening happening in the area, and what are the factors that we need to consider in educating the people in a particular area. So as an example, we currently have low coverage in one of the regions in Mindanao. So for this region, we try to also set dialogues with the community leaders, the elders in the community, to help us convince the people regarding the benefits of newborn screening. I've also mentioned in my talk that the program also emphasizes on education. So currently we are developing materials online, the traditional materials regarding newborn screening. Um, Newborn screening is also included in the high school curriculum, but admittedly we still need to strengthen the education, and we need to be able to integrate newborn screening in the medicine and nursing curriculum. We still need to strengthen that.
Thanks very much. I think we're going to have to move on, and we can take the last two questions. If you will say to whom your question is addressed. Erica?
Good afternoon. My question is actually open to anyone to answer. It seems to me that that the greatest impediment to accessing healthcare is access to transport that is affordable and timely. Is there any country that has addressed this through providing healthcare specific transport? And I'm not referring to transport between healthcare providers, so from clinics to hospitals and tertiary centers, but rather transport from people's homes or communities to healthcare services.
Does anyone have experience of this? It's a common issue, especially in geographically large places.
In India, we have one system where the pregnant ladies are taken to the hospitals with the Janani ambulance. There is a system of ambulances, and they are dropped back after delivery. Other than that, we don't have any such systems where people can avail transport systems. Mostly it occurs between the between the hospitals or among the hospitals.
Thanks. Any other experiences, Michelle?
For the Philippines, we ask the help of the regional offices of the Department of Health. If patients need to be seen in the newborn screening continuity clinics, or if patients need to be admitted in a hospital. So it is through the coordination with the regional offices. But strictly speaking, we still do not have the transport system for specifically for patients with newborn screening disorders.
Thanks. Manuel, any experiences from your side?
Yes, here in Tanzania, we have at least the network of the ambulances from within the healthcare facilities, from the health center, that is at least primary level, carrying patients to the secondary level and to the tertiary level. That one is already in place. At least each ward will have one car or two to be able to shunt people to these largest hospitals. But secondly, the strengthening of healthcare system at the primary level has been a key for the government, because you don't need to refer every patient up to the zonal referral or the national hospital. So this is one of the areas that can be able to help solve such a problem. Only those critical conditions are being referred. Finally, some of the programs that are running within the country are supporting those patients who cannot really afford the transport cost with transport fare. This is not sustainable, but at least it's somehow working to support those who are already in the program. But working with the government structures, using the community healthcare workers, at least there is a way that these people can be advised to at least access a nearby hospital. That is one way that has been very helpful for the Tanzanian program. Otherwise, it remains to be a critical condition, not in all places, but in at least part of the country. Thank you.
Thanks very much. Our last question will be from Dr. Anne. I think if you can put your question in the chat or in the Q&A, we'll see if we can get to it. If not during the hour, then afterwards. But thank you very much, everyone, for your attendance and your participation. I think we had excellent presentations, and it was extremely helpful for those attending to learn what's going on in other places, and that one just needs to start, and that things are achievable over a number, even if it is over a number of years. And that is, that's my experience as well in South Africa. So I'd like to thank all our speakers, Dr. de Costa, Professor Abadingo, Mr. Kowero, and Dr. Nair for joining and for helping with this great study, this great seminar. We will keep the SCAN mailing list updated as we receive funding to allow for more seminars. But thank you, and thank you everyone for attending. And I think, Louis, you wanted to advertise some opportunities. What I wanted to say is that SCAN and so SCAN has a website, and if the speakers give their permission, then this webinar will be placed on the SCAN website managed by the Global Health Network in the next week or two. And then, Louis, there's a new session from the Global Health Network, Empowering Health Education, which is looking at health challenges affecting mothers and children. And you can register for this. There's the QR code, and Louise put the link for registration in the chat. That would be great. Thank you. And then SCAN and Northwest University in South Africa are hosting the 51st International Clearinghouse for Birth Defect Surveillance and Research Project conference in South Africa, just outside Johannesburg, in November this year. And it's the first time that the Clearinghouse Conference is going to be held in Africa, or outside of Europe and the United States, actually, in a low and middle income country. It would be wonderful if people could submit abstracts. There will be limited support for people who've had abstracts accepted from Africa to attend. We have managed to scrape together a few funds for that. And the website is there with a QR code, so I would encourage everybody to follow that link. You don't need to worry about safety. You will be picked up from the airport and taken straight to the venue. So thank you very much, everyone. Thank you to our speakers, and thank you for your attendance this afternoon, evening, morning. Thanks, and thanks, Louis and the team from the Global Health Network for managing the process, as always. Thanks a lot. Bye.
Bye. Thank you.
Bye.
Bye.
Extremely thank you.
Thanks, everyone.
Thanks a lot.
And please join me, everyone, in thanking Emma for her work on pulling together this series. It's been a pleasure working with you, Emma.
That's great. Thanks, Louis. Okay, likewise. Thanks a lot. Bye-bye.
Thanks. Bye-bye.
All right. Thanks all. Bye for now.